Hey, my name is Jeff, and I'm a registered respiratory therapist in the medical intensive care unit. I just recently returned from an awesome 2-week vacation, but today I'm taking care of a mechanically ventilated patient with emphysema. Her name is Mrs. Tubbs. She's 50 kilograms of ideal body weight. She's lived with the diagnosis of chronic obstructive pulmonary disease, or COPD, for almost 10 years now. The attending physician wants to be cautious in the weaning and liberation of mechanical ventilation for this patient, as it has been difficult in the past keeping Mrs. Tubbs breathing spontaneously after her previous extended stays on the vent. So my role in the successful weaning and removal of positive pressure assisted breathing is 1. Do an ABG to check the status of her ventilation and oxygenation. Also want to do some bedside ventilatory parameters such as a NIF and a MEP. We also want to check and make sure her vitals such as her blood pressure or SpO2 and heart rate are all within normal limits. We want to verify that her underlying disease process has been reversed and also make sure that her sedation is off. And then lastly, we want to perform a spontaneous breathing trial prior to extubation. My role in keeping Mrs. Tubbs off mechanical ventilation after extubation is make sure that she can protect her own airway. She can mobilize secretions and also help elevate the head of the bed. We want to do some bronchopulmonary hygiene techniques or exercises, and then also do some necessary meds, PRN if she feels that she needs them, and then also a BiPAP before we decide to reintubate her. So we're currently working with Mrs. Tubbs in the management phase of mechanical ventilation. We need to monitor her ventilation and oxygenation statuses by drawing an ABG. For someone with COPD, it differs from a normal healthy adult lung's ABG. So Mrs. Tubbs' ABG results would typically be around a pH of 7.34 to 7.37. She'll have a PaCO2 and a PaO2 of 55 to 65 torr. She'll have a bicarb of 28 to 34 milliequivalent per liter. Some special precautions that we'd like to take is look at her vitals. Make sure that she's not tachycardic, she's not bradycardic, or that her respiratory rate hasn't been elevated or decreased. Her blood pressure hasn't fluctuated any, and just take into account that all of these haven't fluctuated from her normal limits of her baseline. We also want to look at her physical assessment. She has no increased work of breathing, no accessory muscle usage. She's not agitated. She's certainly not obtunded. She's not somnolent, and she has really good color. We can also look at the vent and make sure that she has good volumes within normal limits of her baseline. So at any time I see a respiratory distress from her, I would stop the weaning process and return her settings back to where she was prior to the weaning process. As we look at Mrs. Tubbs' ventilator settings, we can see that she's on a SIMV volume control mode of ventilation. She has a set frequency of 10. She has a 5 centimeters of water pressure for pressure support. She's on 35% oxygen, and she has only 5% centimeters of water pressure for PEEP. She has a total frequency of 11 at the moment, so she's doing 1 over by herself, and she has a total spontaneous breath of around 492, even though she's been doing around 250 spontaneously by herself. Mrs. Tubbs' vital signs are stable and normal for her age and cardiopulmonary disease history. She has been satting around 91%, which is good because she's within the 88 to 92%. So the attending physician, Dr. Nose, wants me to wean her to a minimal mechanical value of an SIMV rate of 4 due to her long-standing COPD. I can do this by changing her rate every 30 minutes in increments of 2 and manage her FiO2 and PEEP based on her oxygen saturations and pressure support by looking at her work of breathing. I can assess her ventilation and oxygenation via an ABG and non-invasively in looking at her heart rate and O2 sats to see if there are any drastic changes from her baseline. I can also do a patient assessment on her to see if there are any cyanosis, increased muscle usage, increased work of breathing. She's not agitated. And then also I can listen to her and check for any chest rise. So I come to Mrs. Tubbs' room and just found out that she's on contact precautions for MRSA in the nears. So we're going to take some extra precautions. But back to Mrs. Tubbs. So we successfully weaned her to an SIMV rate of 4 breaths per minute. I placed her on a pressure support ventilation, so she's currently on a pressure support of 5 and a PEEP of 5, and an FiO2 of 35%. Fast forward 1 hour, and now we're going to obtain her weaning parameters. The first weaning parameter I'm going to obtain is a spontaneous tidal volume. So what is a spontaneous tidal volume? Well, a normal tidal volume is just a normal breath in and out. Spontaneous tidal volume is whatever the patient's spontaneous breath in and out. The normal is in between 6 to 8 mLs per kilogram. A respiratory rate is the second thing we're going to look at, which is typically between 12 to 20 breaths per minute and no more than 30 breaths per minute. Third thing we're going to look at is Tobin index. This can be calculated by doing frequency divided by tidal volume. The normal is no greater than 100, which is the rapid shallow breathing. So we should have normal breath, but with higher volumes. Fourth thing we want to look at is vital capacity. Vital capacity is the maximum volume of air inhaled and the maximum volume of air exhaled. The normal for this should be 10 to 15 mLs per kilogram of ideal body weight. Fifth thing is a NIF, negative inspiratory force. We do these to test the muscle strength to see if the patient, Mrs. Tubbs, can protect her airway off the vent by coughing. The normal should be less than or equal to negative 20 centimeters of water pressure. Anything more, that's great. The last thing we want to look at is non-invasive oxygenation. We can do this via pulse ox, which normally in a normal healthy person is 92 to 100. For her, her pulse ox saturation should be between 88 to 92%, given her COPD status. The next non-invasive thing we can look at is carbon dioxide levels. And we can do this via using an end-tidal CO2 detector. Update on Mrs. Tubbs. She has finally passed her weaning trial and she has successfully been extubated. Now she is currently on 2 liters of nasal cannula, but almost immediately after I extubated her, she's starting to desat down to about 82%. She's becoming tachypnic. So after assessing her, she's performing a rapid shallow breathing technique. So I've obtained an ABG and can almost already predict that her ABG results is going to be an acute alveolar hyperventilation superimposed on chronic vent failure. So in this case, her pH is going to be increased, her CO2 is going to be increased, and her bicarb is going to be increased, but her PaO2 is going to be decreased. So everything's going to be increased except for her PaO2. So I spoke to Dr. Nose after looking at Mrs. Tubbs' ABG, and we've come to the conclusion that she needs to be on a BiPAP therapy. So the first thing we need to do to help her spontaneous breathing, to get her on the BiPAP, is we need to measure for the mask. So it looks like she's about on a medium face mask. So now we're going to put her on the face mask. In this case, we're going to do a face mask as opposed to a nasal BiPAP, is because she's a big mouth breather. So we're going to do the mask and benefit her the most. Bear with me, Miss Tubbs. I'll make sure we got a good seal. No leaks. Good. So now we're going to do our initial settings. So to start with, we're going to do 10 over 5 and 60%, just to start with. So she's on 10 over 5 and 60%. Now we're not going to keep her on that, we're going to titrate her accordingly as we look at her and look at our volumes and everything. Second thing we want to do is go to our alarms. So we got our high pressure alarm, we want to set that 10 above, and our low pressure 10 below, whatever she's getting. Our apnea is always about 20 seconds. Our low minute ventilation is 1 below, and the high rate and the low rate is going to be based off of whatever the set rate is, or whatever her rate is. So you want to take 1.25, multiply it by whatever she's getting, and in this case she's getting 16, so it would be 4. So we're going to do 4 above the 12 or the 16, so it should be in a high rate of 20 and a low rate alarm of 12. Now we want to continue to assess her and to figure out the effectiveness of this based on her ABG results and then also by some simple patient assessment skills. Mrs. Tubbs' respiratory status is beginning to worsen on the BiPAP. So if we were to draw an ABG right now, she would certainly be a respiratory acidosis. Her pH would be decreased, her CO2 would be increased, and her PaO2 would definitely be decreased. If I did a patient assessment on her right now, she'd certainly be pale, increased work of breathing, diaphoretic, intercostal retractions, and those are just some of the acute changes that happen. We called rapid response, but to be honest, this should have been called right after she was extubated and found out that her respiratory status was decreasing rapidly. So while I'm waiting for rapid response, things I need to do is I'm going to continue to do my patient assessment. I'm going to make some vent changes on the BiPAP if need be to help with the comfort levels and the decreased work of breathing. Also, I'm going to get the intubation equipment ready along with some of the drugs, the paralytics, and the sedatives. With my intubation equipment, we have ET tubes. We got 1 above, 1 below. We have a syringe to inflate the bulb. We have a laryngoscope with a Mac and a Miller. I want to make sure the light works, and it does. Good. We have a colorimetric just to make sure that we're in the lungs. We have an ET tube holder after we secure the airway and make sure it's there. We're going to put this on there to secure it. Also, we're going to have a bag valve mask. So it's the number one thing that we need to have so we can bag them right after, or if we don't get the intubation, then we'll just bag them. Hey, my name is Jeff and I'm a registered respiratory therapist.